Thanks so much for joining me on the Slice of Healthcare podcast. How are you today?
Doing well, Jared. Thanks for having me.
Absolutely. I'm excited for us to chat. I've done some research on the company. I'm a fan of what you've been building, and I'm excited to finally have the opportunity to kind of hear more about your background, the basically why, how, what of the company, and really what you're most excited for. So let's dive right into it. I'd love to hear about your background.
So, I'm a doctor by training. I'm actually a cardiologist. And, when I came home to join my father, who had a very unique medical practice at the time, I discovered that there were two major issues within healthcare. The first one was primarily a challenge of, our outcomes and what we were delivering as a healthcare profession. And the second one is this massive disparity that exists between, people of different socioeconomic incomes. And so ChenMed was formed to tackle the woes of those two pieces. So we have a major drive towards healthcare transformation and a major drive towards social justice. I could give you a little bit more color there. So let's talk about how we do things a little bit differently. So we discovered that there are these neighborhoods in every U.S. city today, these zip codes, in which if you look at their average life expectancy, that number tends to be around 20 and sometimes as high as 30 years below zip codes of higher incomes. So that is a fundamental problem, right? So if you're in New Orleans, there's a zip code there where the average life expectancy is in the late 50s, about 57 years old, just 3 miles away, same city, a zip code where the average life expectancy is 83 years old. So we thought about doing something about that. That's the first thing. The second thing is, we need to do something about the fact that we think there's something called perverse incentives. I'll give you an example. As a heart specialist, I went to Boston to do my medical training at one of those Harvard hospitals, and then of course went to do my cardiac training at Cornell on the Upper East Side. That's where a lot of the hedge fund people and different stars, they all go to New York Hospital, famous heart surgeon and heart center. And I left there with the equivalent of about 5 board certifications. So really well trained in cardiology. If you were to ask any cardiologist in the U.S., you said, how much of your patient's health, or how much is heart disease or heart health is due to lifestyles and behaviors? What most cardiologists would tell you is that, of course, somewhere between 80 and 90% of heart disease and heart health is due to, lifestyles and behaviors, eating well, keeping a low stress level, not smoking, exercising, right? This is nothing new. Then you just say, well, Chris, with all of your, sort of prestigious training and schooling, how much training did you get on lifestyles and behaviors? And the answer is 0.
Wow.
Not even a 20-minute class. And what was the equivalent of close to 15 years of schooling for the normal, person to be a cardiologist?
Out of curiosity, why do you think that is? Real quickly before we dive into
Well, that's the piece that we wanted to transform. So we had to transform 2 things. We had to transform the fact that, a lot of these neighborhoods have these massive disparities. That's number one. And number 2, we had to figure out how to transform the way healthcare is delivered. And we thought one of the key ways that you can do that is by fundamentally changing the healthcare system of being one that treats sickness to one that figures out how to prevent sickness. So here's what ChenMed did. We had a hypothesis. We said, what if we took a really well-trained doctor and we said, doctor, you're now going to be the quarterback of delivering health, not of just fixing heart attacks and strokes and cancer. No, we want you to target health in a group of patients. And so the first thing we did was we said, hey, doc, you can't see 3,000 patients. In our neighborhoods, the typical primary care doctor is taking care of 3,000 patients. We said, doctor, you should see about 400 patients, because the patients that you're going to be taking care of are the oldest, some of the poorest, and some of the sickest people. And you need to get on top of all of their healthcare challenges. You need to get on top of their medicines, of course, and on top of their procedures and specialists. But even more importantly, you need to take a more holistic approach towards prevention by improving their lifestyles and behaviors and what I call, social barriers to care. You have to figure out ways to overcome social barriers to care. So what's a social barrier to care? If you don't have a ride to the doctor, that's a social barrier to care. If your grandson is stealing your Social Security check and you don't have any money, that creates a barrier to care, right? If you're food insecure, if you're worried about your own physical safety, if your heat's going to get shut off and you're in West Philadelphia in the winter, that is going to impact your health. So we said, take a doctor, give them amazing tech and an amazing team, 2 things. And you should be able to make a huge difference in that population that you've been assigned. And so that's what we started in South Florida. We started that model in South Florida, and it was very successful. And so then we questioned, could we spread this to the rest of the country? The good news is right now, we have a model where doctors give away their cell phone numbers. They are seeing patients, or at least touching them either virtually or in person, anywhere from every 2 to 4 weeks, During COVID, obviously, we've had to find virtual ways to do that. And the results that we get is, here they go. We reduce pretty predictably across all of our markets hospitalizations by 30 to 50%. We're able to prevent them, all right? What else are we able to do? Then our net promoter scores, of course, they're through the roof. Why? You take the old, the poor, and the sick, who are usually, they don't even have doctors that take care of them. They have to go to the emergency room when they're in trouble. And then you have them partnered with, a primary care physician that gives them concierge medicine on steroids and door-to-doctor transportation, and before COVID classes, to teach them Tai Chi so they don't fall and break their hip. During COVID, go to their house to make sure they have paper, toilet paper. We do love calls once a week just to make sure because they're scared to death of COVID and during the COVID time. So we're able to do that. And so they get concierge medicine on steroids. So patients love it. The payers, the insurance companies, they love it. They love it because why? We are able to bring down the cost of care. Why? Because if you can reduce hospitalization rates by 30 to 50%, you're going to make a huge impact on the cost of care. So we found that this is a model in which everyone wins. And so therefore, we're on this journey right now to try to spread this concept throughout the country.
Well, thank you for all that you're doing too, and it's great to hear those stats that you're able to. No one wants to go to a hospital if they don't have to, right? And if you're able to limit the times that they're actually going, it's no wonder why the payers love you, but it's also no wonder why the patients love what you're doing as well. So thank you for all that you do. In this model, who typically who pays, I guess?
Yeah. So we are exclusive geriatric practice, right? We discovered, there's a tremendous amount of need, but we said you can't be everything to everyone. So we decided that in order to truly scale, we had to focus. And so who do we focus on? Predominantly people 55 and older. And then what we had to do is we said, well, we need a payment model that allows us to invest in patients and then bring down their costs later on, right? So, during COVID, everybody was really rushing. They were saying, hey, we need to get telehealth paid for. We need to get telehealth paid for. We didn't wait. We actually internally made a decision, and 1 week later, we turned everybody virtual in 1 week because we didn't have to wait for our payment structure change. We were fully capitated. Now, what does it mean to be fully capitated? So we only work today with Medicare Advantage plans. In the future, clearly, there's, we're going to be working with the novel payment models that are coming out through Medicare, in which we were an important part of actually helping to come to fruition. And so, but this concept of taking a lump sum payment where you could, invest in the patient upfront to see them more frequently, to give them more primary care, not less primary care, to give them more access, not less, to actually start to worry about toilet paper and other needs that they could need during, either a pandemic prior or before. They all have unique needs. And we have to be empowered and have the financial backing to be able to solve those challenges, to thereby reduce the hospitalization rates by 30 to 50%. So we only work in a capitated environment. We do not do any fee-for-service work. So we're extremely focused. And so our payer today are Medicare Advantage plans, the largest ones. You can go in order. You have the United, Humana, Aetna, which used to be WellCare, now is Centene, HealthSpring, and a whole series of Blues as well that we work with. I think the total number of payers that we work, unique payers we work with across all of our 24 cities is, I think it's about 22. So they're excited about it because think about it. We actually take what usually is bad business for a payer, right? It's that 5 to 15% of the population that drives the majority of the costs. We take that risk away from the payer, and we said, hey, let us deal with that, and we'll figure out a way to make it work and deliver superior outcomes, and find a way to substantially improve the access and the perception of the care.
That's interesting. Wow, that's a great model. Yeah, I mean, when you look at the majority of their, I don't want to say headaches, because people getting sick or at that age, it's just you're more likely, right, to go to a hospital or to spend more on healthcare after you're 55 and older, right? But it's nice, especially for them and for the patients. It's nice knowing that you're helping in an area that's really driving a lot of their expenses. So thank you for everything that you're doing. I'd love to quickly focus in on some of the things you're really excited about in terms of ChenMed for as we go into the rest of this year. What's like on the horizon that you can discuss?
Yeah, sure. So first of all, the market is huge for what we're trying to do, right? And so Medicare Advantage today, roughly about a third of Medicare recipients have Medicare Advantage, and it's continuing to climb. And so Medicare Advantage is the sort of the marketplace today that we're able to, create these amazing outcomes for people who really need it. Again, transform the way that care is delivered, and also, achieve social justice. I mean, we actually equalize in many of our markets, equalize the outcomes between the richest people and the lowest income people, which are our patients. So we're really excited about that. So the question is, what does the future of ChenMed look like, and what does that market look like? And I can only think it's all positive, right? If you can systematically reduce hospitalization rates, if you can systematically improve net promoter scores, if you can systematically reduce the cost of care, and you can systematically equalize racial disparities and socioeconomic disparities, that is a great. There's tremendous demand for that, and that demand is actually growing. Why? Medicare Advantage recipients, number of people having Medicare Advantage going up. Number two, we're hearing about all these novel payment models that are coming out through Medicare, through CMMI, to help so that way we can help people who aren't in Medicare Advantage, and that's going to be a huge opportunity for us. So our major focus today is how do we get out to as many of these neighborhoods as quickly as possible. When I present to my board, we tell them about our growth rate, which is very good. We tell them about the fact that each of these markets and centers they break even pretty quickly, so the model is sustainable. Okay. We talk about how it's able to replicate across many different geographies and maintain the similar type of results. So we know that it's predictable and it's replicable. And just as I'm starting to feel good about myself, the board looks at me and says, how do you sleep at night? I go, what do you mean? He goes, Chris, the organization's delivering results that substantially improve life, and they're doing the right thing. You have a moral obligation to grow as quickly as possible, to get the solution out as quickly as possible. It's almost like saying, if you have a cure for COVID, like a vaccine, you have a moral obligation to get that vaccine out to as many people as quickly as possible, especially those most vulnerable. And our patients are the most vulnerable, right? Our average age is 72 to 74. 75% of our patients have 5 or more major chronic conditions. 90% of our patients are within 300% of the federal poverty line, right? So this is the old, the poor, and the sick. And if you look at just in terms of minorities, over 50% of our patients are minorities, where African Americans actually greater than 70% are minorities. So, so we're excited about the future. We are extremely focused from a mission perspective in delivering what we can to our population that really needs it. And then, of course, at the same time, we're doing our best to partner with either different hospitals, different plans, different health organizations, and helping them create models that would be relevant in the future. Because I think the relevance of the traditional fee-for-service, we celebrate when people get sick model, or at least we financially celebrate when people get sick model, is something that's going to be less relevant in the coming 3, 5, or 7 years.
That's super interesting. And you're right. There is a moral obligation to, when you have something like this, to continue to get it out to as many people as you can because of how much it helps them. So thank you for all that you do. And I just want to highlight too for our audience, just so they know, the goal is to have you and other members of your team on the podcast. And we do these basically micro segments to kind of highlight, this is your intro podcast, but to highlight different areas of your business, cool new wins that are happening for the company to let everyone know. And some other things. And we're actually launching coming up a cardiology podcast. So maybe there's an opportunity to have you on that. And you're speaking with a cardiologist, you're not speaking with me. So you can talk about, you can get as technical as you want, but I'm really excited to continue to build this relationship with you and ChenMed. And thank you for all that you do. And again, thanks for being a guest.
Jared, thank you so much. What a wonderful opportunity.